Right. Good morning, good afternoon, and good evening to everyone, and welcome to UCSF Center for Global Nursing Impact Series. This series aims to provide a platform for our nurses and global partners to share their remarkable work, offer valuable insights, and inspire our global community. Following the presentation, there will be a short Q&A, so feel free to write questions throughout the presentation in the Q&A box. My name is Dr. Rebecca Silvers. I'm Director for Center for Global Nursing, and it is my pleasure to introduce this month's speaker, MaryJoy Kaimuri. Dr. Kaimuri is the Dean of the Meru University of Science and Technology, the School of Nursing in Kenya. She holds a Bachelor of Science in Nursing, Master of Science in Health Systems, and a PhD in Public Health. She is also a 2023-2024 DAAD IDC Fellow, which is an international program that equips academic leaders in low middle income countries with advanced training in higher education leadership. In addition, she's currently serving as a micro research coach in partnership with Dalhousie University in Canada. In her leadership role, Dr. Kaimuri oversees faculty, staff, and students while strengthening community and clinical partnerships that support student training and research. She has been honored by the Health Systems Management Association for her outstanding work in student mentorship and her contributions to education and health system strengthening initiatives across Kenya. Dr. Kaimuri is also one of our esteemed members of the Global Nursing Advisory Council here at CGN, where she collaborates with our council to support elevating the voice of nursing across the globe. Her work spans multiple disciplines, and she has a deep passion for community health systems and its role in advancing equitable care. Her research focuses on clinical mentorship, maternal health, and reproductive health, reflecting her dedication to women and children's health as the cornerstone of resilient communities. I am very honored to welcome Dr. MaryJoy Kaimuri to this month's Global Nursing Impact Series. And with that, I will hand it over to you, MaryJoy.
Thank you. Thank you so much, Rebecca, for that very good introduction. And I feel excited and honored to be sharing with you about our community health model that we're implementing and the impact that the nurses are making in this particular model, because they are the drivers of the model in collaboration with other healthcare workers. And I'll just get into it. And for us, the community health model provides services, and the main mandate is to bring services and health interventions closer to the people. And you find that our people, most of them will live in villages, in very rural areas, and in various communities. And therefore is to decentralize the healthcare services to these particular persons. And the model is mainly, it focuses on primary healthcare. I'm sure those of us who know about the Almata Declaration that brought about the primary health care that focuses on essential care that all of us should have access to. And also, the focus is also to help the communities to take responsibility for their health through their own participation. And therefore, this model creates awareness about health matters and health issues and encourages health-seeking behaviors. And for this particular model to work, the implementers are what we call the community health volunteers, and currently we are calling them the community health promoters. And these are the ones who are doing the actual work, and of course, assisted by the nurses who are at the primary healthcare facilities. I'll be showing you what our primary healthcare facilities are in a short while. And for this model to work again, usually we do mapping of the communities, and we divide communities into units. And every household will belong to a unit. And a unit is made up of at least 500 to 1,000 households, or about 5,000 people. And you'll be seeing that in a short time. So this is how our healthcare system is organized. And you can see at the bottom here, we have community health services. And this is where we have the community health units in our villages and in our communities. Then you have the primary health care services as a second classification, where we have our dispensaries and our health centers. And then above that, we have the county health services and the national referral services. And maybe what I can say at this point, our healthcare system is organized or arranged according to our administrative structures where we have a national government, and then the country is also divided in counties, and therefore we have services that are provided by the national government. I think this is what would be equivalent of the federal government for those who are in the US, and then you have the county healthcare services. And on this other side here, you can see our level 1, which is our entry point of our healthcare services, are the community health units. These are the house zones, the villages, the communities. And then level 2 are the dispensaries, and then level 3 are the dispensaries. So level 1 to level 3 is what we call our community health services. And this is where the community health model is mainly focused. And then from level 4 to level 6, these are curative and specialized kind of facilities, where if from the lower levels, from the level 3s, if something is not able to be handled at that level, then the referral goes upward. So that tells you that our referral system is from level 1 going all the way to level 6. And this is how our primary healthcare units look like, or networks. So if you start at the bottom here, you can see this is a population being served, and these are the villages and the communities that are down here, which are manned by the community health volunteers and the community health promoters. And then these are referred to the primary healthcare facilities. These are the dispensaries and the health centers that we have seen. And you'll find that the core staff, the main human resource that you find at our level 2s and level 3s are the nurses. And then if they're not able to handle anything at this level, then they can refer to the level 4, who will refer upwards. And I've talked about a community health unit. These are our community health unit will look like. And it all begins from down here. You can see we have house zones. And as I've said, these are house zones that are located in the communities and in the villages. And therefore, one community health promoter is supposed to take care of at least, on minimum, 100 house zones. And usually, on average, according to our fertility rate, each house zone is averaged to have 5 members. And therefore, that is why when you calculate, you find that we have these 5,000 people here. And therefore, if you have 500 to 1,000 house zones, they will be taken care of by 10 community health promoters. And you find you have a community health nurse here, or a community health assistant, who is supposed to be supervising the 10 community health promoters to check what they are doing at the house zone level. And that becomes a community health unit. And that is how the community health model is organized. And you find that the people who are in the villages, the entry point, which is a community, are the community health volunteers, or are the community health promoters. And it is good for me to mention how they are selected, because these volunteers and promoters, they're supposed to be persons who reside within that community. And therefore, they should have resided in that area at least for 5 years prior to appointment. And during appointment, remember we've talked about community participation. And because this model is owned by the community, you find that the chief or the leaders, they call what you call ambalaza. Ambalaza is a meeting of all the people in that particular area. And it is the people who will agree on who is going to be their community health volunteer or promoter. And once that person has been selected and they have agreed to take up the role, then they are trained. And the training, there is already a curriculum which has some basic modules and some technical modules. And these modules, if you can look at some of the topics that they are covering, there are issues to do with community, how you bring people together, how you promote this, how you promote health, how you prevent diseases, and how you do disease surveillance, because that is one of their roles. And also on issues that are aligned to primary health care elements, which are on essential health care, which mainly are on maternal health care, family planning, HIV, issues of water and sanitation, because those are mainly the issues that most of the families and the communities will be actually dealing with. And the roles of the community health volunteers and promoters are, again, aligned to some of the roles that they carry out. And of course, their roles are aligned to the primary health care elements. And mainly, you find that they will be implementing these elements in the community and in the households. They'll be doing some general health monitoring. And at this point, I can say that in our setting, we are now struggling with the communicable conditions like the malaria and the HIV and the tuberculosis and others. And at the same time, we are now also struggling with the non-communicable conditions. We're having a lot of diabetes, a lot of hypertension, a lot of heart diseases and all that. And therefore, the community health promoters, they also help us in doing some general health monitoring. And they do that. You find that one of the things that they do, you can see here they have a kit or a bag, and it has an BP machine, for example. It has a glucometer, and they are charged with the responsibility of monitoring blood sugars and BPs and being able to record that. And especially for people with diabetes and high blood pressure, they're supposed to be able to do fast aid. They're supposed to also do disease surveillance. So if there is an outbreak in the community, they're supposed or in the households that they are taking care of, they're supposed to be able to notice that and report. Yeah, and they're supposed to report in the facility, whether a dispensary or a health center that they are linked to, and the person that they will report to most of the time, he's a nurse. They're also supposed to do defaulter tracing and contact tracing. Again, this one is very important for us. Like if the nurse at the health center notices that there's a child who has missed a vaccine or immunization, yeah, they're supposed to contact the community health volunteer or promoter in the locality of where the family is located and the child is traced. The same thing if, for example, we have a new diagnosis of a TB case, again, we are supposed to test all the contacts of that particular person. And therefore, it is a community health promoter who goes to the home of this person and they trace all the contacts that this person has come in contact with. I talked about basic screening. They also do referral and linkage. So if they find, for example, a mother, for example, who is pregnant and they have not started the antenatal care visits, again, they link them up to the dispensary or health center for those particular services. They also maintain the household records. So if a community health promoter has 100 households, they are supposed to maintain all the health records of those 100 families. And to be able to do that, you have a mobile phone-based platform that we call EKIS, or the Electronic Community Health Information System, that they're able to put all that data, and we are able to access that data from the health facilities all the way actually to level 6. We are able to access that information. And then they also organize community dialogue days. Community dialogue days, these are just conversations with the community. Again, because of the surveillance that is happening, we are able to be able to identify health issues and matters that are prevalent in a particular community. If, for example, you are seeing a lot of outbreaks of water-based diseases or sanitation-related issues, then we can call the community members together with the health team, and we have a conversation that we're having this issue, and we come together and come up with interventions. What do we need to do to solve the problem that we are having? And apart from this conversation, these community conversations, apart from them helping us to solve the issues that are there in the community, they also provide a very important platform for creating awareness on health matters and emerging issues that are there, that are coming up, like climate change and other health issues that are happening within our communities. And you find that these dialogues, the nurses who are within that locality or the catchment area, they are part of the health team that drives that participate in these community conversations that happen 4 times in a year. So we have one every quarter. And these conversations, again, they are based on the health matters and health issues identified from that particular community. And again, you can see the issue of community participating in this conversation and also coming up with interventions that are going to help them manage the health matters in that particular community. So in the platform, the community health promoter is supposed to be able to capture all this information. And maybe I can talk about the household registration, because that is what is the starting point. If, for example, a community health promoter comes to my house and I have 5 members, they're supposed to take data for each of the 5 members and document. They're supposed to document if I have any children who are under 5 and the status of those children. They're supposed to also document if I have other children who are over 5, their ages, where they are, and what their health status is. Also document if there is any person within the household that is elderly, that has a disability, that has a chronic condition. They are supposed to also document a status of immunization. Again, if you have under 5 children, for us, immunization is a mandatory requirement for all the under 5 children. Again, they're supposed to document the status. Also, if there is any family member who is pregnant and if they are attending the antenatal care and if they are receiving the care that they need. Also, for mothers that have delivered and they are at home during the postnatal period, they're supposed to document, is a child breastfeeding well? Has this mother gone for postnatal checkups? Family planning also, information is put there, and the photo tracing that we talked about. And then remember we saw the under bag, they have a kit, and that kit has some supplies, like for example, for the glucometer, it has the sticks. So they're supposed to keep count. And also they have some basic medications like medications to deworm the children and all that. So they're supposed to keep count of those supplies. And if they run out, they are supposed to again go back to the dispensary, and the nurse is supposed to help them in refilling that. And also, they also record the status of sanitation, hygiene, sexual and gender-based violence, because this again is an emerging issue, socioeconomic issues, and also follow-ups. And also an important thing is if a member has migrated out, they are supposed to mute them in the platform. If a member has passed on, again, they're supposed to mute them and also report the death, because sometimes we have deaths that are occurring within the households. Now, in all these, what are the roles of the nurse? Yeah, because that is, we are looking at the impact that the nurses are making world over. And from where we started, I said that in our primary healthcare facilities, which are the dispensaries, which are level 2s, and the level 3s, which are the health centers, the core staff, actually the 99% of the staff in these facilities are the nurses. And therefore you'll find that the nurses, they become the driver of the model, because they become the linkage to the community health promoters, supervising what they are doing and ensuring that they are well supported. And also in this, in our community service or in the community health model, you find that the nurses are very critical, because they are the ones who provide all the curative care, all the preventive care. In fact, if you go to a dispensary, you'll not find a doctor. Actually, the person you'll find there is a nurse. So if you come and you have a cough, it is a nurse to know how to deal with that cough. If you come and you have a child that is that requires vaccines, it is a nurse who is going to do that. So you find that the nurses that are placed in the dispensaries and the health centers, they are supposed to be very, very well qualified and very, very well aware of the most prevalent and the most endemic health issues in the communities that they are working in, because they will be expected to provide all this care. And then all our maternal and child health care services, again, they are provided by the nurses at the dispensaries and at the health centers. This ranges from the antenatal care. You'll find they're the ones who are going to prescribe and give the supplement for pregnant women. They're the ones who are going to do all the antenatal profiles that are required, interpret them, and be able to provide care. They are going to also conduct deliveries. Deliveries are conducted from level 3, which are health centers. So every health center has a small maternity unit of about 8 beds, and therefore for uncomplicated deliveries, the nurse is supposed to be able to assist and help the mother to deliver their child. If there are any complications, or if during monitoring they find that this mother, for example, require more care or require a C-section, then that is when they have to refer them to the level 4 and upwards. Also, family planning, again, apart from the surgical family planning options like the tubal ligation, all the other family planning methods, including the implanon, the IUCD, all those are administered by the nurse at the health facility. And therefore, if the community health promoter refers a mother or a woman from the community, the first person they meet to give this family planning, it is a nurse. All immunizations, again, they are given by the nurse. Actually, the nurses are the ones who manage all the vaccinations, from the records, vaccination itself and keeping records and all that. Then also, if the nurses are the ones who are supposed to refer to the level 4s. So if again there's something that cannot be handled between level 1 and 3, they refer upwards. And also they are part of the community health committee that actually helps in managing the community health units within the catchment area. And also they are in charge and they participate in supervision of what the community health promoters are doing. So again, they're supposed to be checking through the various documentation to make sure that the documentations are complete, that they're able to capture those who have been referred, and they're able to, again, collaborate very closely with community health promoters to check, for example, those who have defaulted, to trace those who need to be traced and to deliver the care. Also, refilling of the community health promoters kit or bag, the first aid supplies, the evening medications that they are going to have, the servicing of the equipment that they have. It is the role of the nurse to be able to do that. And the most important thing is that the nurses, they have a key role in our nursing education, because in our curriculum, our nursing curriculum, right from diploma upwards, they have a component of community health, which forms about 20% of the nursing curriculum. And you find that the nursing students are placed either at the dispensaries and the health centers, and from there, they're supposed to be able to visit homes and households. So they are going to be able to do that with the linkage to the community health promoters, so they can be able to visit people in their homes and be able to provide care there. They are able to also be able to go to schools, be able to go to places of work, and be able to assess and do diagnosis and come up with interventions to help maybe the school populations and also the working population. And also for us now, it has become very easy when you are doing community health research, because all we need to do is go to a dispensary or a health center, and we are linked to the community health unit of the area that we are interested in. And therefore, it becomes very easy for us to be able to carry out community health research, to do community health interventions, provide health education, and even do screening within the communities, because like you find we continually do what you call community diagnosis to be able to identify health problems that are within our communities. So the nurses become a driver of the community health model, because they are the linkage between the community health promoters and the higher level facilities for provision of care. And finally, you can see from this picture, these are households, and you can see this, you can look at these as the people and the people who are providing the care, and us being able to protect our community health. And we say in Swahili is our language, and we say afya yetu jukumu letu. It translates to our health, our responsibility, because every one of us is supposed to get involved, is supposed to participate, so that we can be able to guard our health and to make our health better. So our health, our responsibility. And with that, thank you, and back to you, Rebecca.
Wow, MaryJoy, I think that was such an incredible presentation. When I think about what the International Council of Nurses, what Howard Cotton, the CEO, talks about, what Dr. Amelia talks about at WHO, it's all about universal health coverage and how important and the large role that nurses play in just making sure that all members of our community, all members of our population have access to care. And I'm excited to hear this model that's rolled out in Kenya, and how you really seek to not to reach the population, and not only reach them, but it sounds like to engage them in their own health and empower them to be leaders in finding solutions and working towards their own community health improvement. Let me quickly see if there's any questions in the Q&A. I don't see any yet. We have just a few minutes. I wonder if you could share with me, because I don't know anything about the health promoters, and it sounds like they work with them really closely with nurses. Do
Mhm.
nurses provide them education? Is there a training for this role? Where are these maybe perhaps young students looking to go into nursing, or is this a role that people are really interested in honing during their to remain in their communities? Could you share a little bit more about the health promoter role?
Okay, thank you, Rebecca. Yes, usually the community health promoters is actually a concept that we have started implementing in the last 2 years.
Mm,
Previously, we were calling them, remember from the primary healthcare, we had the community-based healthcare, which was run by the community health nurses.
oh,
But now we didn't have enough nurses to be able to go around all the communities. And that is why communities were told to identify those members within their communities who are literate, who are also technology savvy, because there is a platform that you have to feed all this information and who can represent them well. And these persons, they are taken through a training, quite an intensive training, which are some basic models and modules and also some technical modules. And this training, it basically covers the most common issues in the community in terms of disease prevention. It will look at issues like water, issues like sanitation, issues like hygiene. Nowadays, they have also incorporated the gender-based violence, because now that has become a problem for us also. And also, just matters of just basic screening,
mm,
because again, there are people who will never come to the hospital, but they'll be running around with their blood pressure. So if there is somebody within the community who, when they are doing their own visit, they can take your blood pressure. If they find it is out of range, they can link you to the health facility. Also, they also check if, for example, I have a diagnosis of diabetes, that information they have. So they also, when they come to my home, apart from taking my blood pressure, they have to check if I have gone for my follow-up clinic in the hospital, and if I am compliant to my medication.
mhm.
And that has actually helped us in managing in management of some of the non-communicable conditions, because now we are struggling with them. They are not a problem maybe 15, 20 years, but now they are a problem for us. Yeah, and also things like immunizations, which are mandatory for us. We are able to see all the children immunized. We are able to see pregnant women, for example, going for antenatal care and are then delivering with the help of a skilled health provider. Because again, we have quite a high maternal mortality rate. So those are just some of the things that they are trained on.
Yeah, decentralizing care. It's an incredible
Mhm.
thing. I think in the US where we're based, it's not quite as well developed. And I think what you're doing is so remarkable. I wonder, I'm sure there's research studies ongoing looking at the impact of this work. Are you aware or involved in any of that work or your school?
Yes, we are involved in some of the studies that are going on in the community. And I remember when initially it started, there was some resistance that why do we need these people? But from the surveys that we are getting from the community, is now people have started understanding what the role of these people are, and they are seeing their importance in involving them in their own care and in coming up even with their own community interventions, depending on what is the most prevalent and emerging issues in that particular community. So people have accepted them, and we are seeing some of the surveys are saying that people can actually see their impact,
Oh,
especially in disease surveillance.
yeah.
In disease surveillance, because you can imagine when you're in the hospital as a nurse, you may not know what is happening deep down in the village.
Mhm.
But if there's somebody there who says you have a diarrheal disease, then you know what is coming and you're able to prepare for it.
Yeah.
Yes.
I think acute issues, people seek care very quickly, but when you have those chronic, non-communicable diseases, particularly screening in the community, going to where people are, because for them to access care means a day off work. It means a day away from family,
Mhm.
a day away from the farm. It's not always possible. So integrating those screening services within the community really allows those things to be identified, to your point, early so that people can
Mm-hmm.
know who needs to get treatment so that they can optimize their own health care. And I think this is such an exciting model that you've shared today and that we get to learn from. And I'm really, really grateful for your time. We're going to wrap up because we've hit the half an hour, but we look forward to hearing more about this work as it progresses. Thank you so much for your time, Dean Kaimuri, and for everyone for joining us today. And we'll be seeing you next month on the second Tuesday. Have a wonderful day, everyone, and thank you for joining.
Bye.